Hello, everyone. It's my pleasure to be hosting the next episode of Bringing AI to Life. Today, I'm extremely excited to be joined with Dr. Arun Govindarajan, someone whom I've known not for a very long time.
Hi, Chiranjeev. Thank you for inviting me to the podcast. So, I'm Dr. Arunkumar. I'm a radiologist. I'm one of the directors as well as a radiologist in Aarthi Scans Labs. So, I did my undergraduation in Tirunelveli Medical College, post-graduation in Mahatma Gandhi Medical College, and I did my FRC here after that. We are one of the largest diagnostic provider with pan-India presence, I can say, with presence in 10 states.
Dr. Arun, as you said, Aarthi Scans has been in existence for more than 35 years, presence across the country and growing. Can you share a bit more about the values and the main mission behind Aarthi Scans?
So the entire value can be informed by our vision, which is the cost to diagnose a disease should not make a patient poor. That is, treatment becomes unaffordable. And this is a vision we believe is worth fighting for.
Which means you have to, at one level, keep your prices low to serve everybody in India, from the biggest cities to the smallest towns. And in the same sentence, you mentioned you do that by using technology. Now, most people think technology is adding cost. It's making things expensive, right? But you are trying to do something which is actually the opposite. So can you talk more about how you've used technology, especially something like as new as AI, right, to drive to the mission?
So technology as it is actually should bring cost down. That is the purpose of technology. Technology is like any machine. Technology is basically what used to be machine is now IT technology now. A machine is something which should have, which should make a man's work easier, and it should bring the cost down. So I would say efficient use of technology like digital pathology and decentralized teleradiology with good and easy to use workflows. This is essential for a good integrated diagnostics player. For example, I can say how technology will bring costs down is we have a radiologist in all of our diagnostic centers. So when he's on leave, we don't have to look for another temporary radiologist or locum radiologist. Since we have a decentralized flow, someone in Delhi could report a case taken in Chennai. So that will bring your cost down, not looking for a temporary radiologist. So all our history is digitized. So that is one more thing. Like we try to save on paper costs. We don't use paper. We try to reduce as much paper as possible. History or consent forms and everything is digitized. So these are small steps we take to reduce prices as with technology. And AI as it is, I'm seeing that will bring more costs down.
You know, anybody can bank from their phone now. You don't really, so they've made it so easy, so accessible. And I think what you're stating is trying to do the same.
So the effective use of have come down.
Yes, exactly. So let's talk a bit more about AI. Can you share how did you get introduced and what made you consider adding AI to your workflow?
Okay, I think around 2.5 years before, I used to ridicule AI companies like how a computer is going to report radiology image, which is so unstructured and there's so many moving parts, little moving parts are there in the image. Like I was in a ridicule phase at that time, and one fine evening, I uploaded a few cases in Qure portal. That was my first, first intro to radiology, you can say. I was just I stumbled across a Qure and I uploaded a few CT brain images into Qure portal. You have a demo portal in Qure. I uploaded a few cases there, I think 4 to 5 cases, and I was astonished. Like, how could AI provide so much? It was basically telling about infarcts, fractures, and hemorrhages, which are the 3 most important critical findings in emergency CT brain. And quickly I got to know that how much enormous value this could provide to our patients and referring physicians and radiologists in critical care. So then I started demoing QXR as well. And then I started talking with Qure. I think you were one of the very first persons I talked to. And then we demoed, 400 cases of chest X-rays. And I got an interesting that help them found two chronic fractures and two small nodules which were missed by a radiologist, but Qure found that. And Qure missed a few findings which were reported by a radiologist. So I thought Qure plus radiologist will equal 0 missed findings. CT brain algorithm, the threshold I think was low for hemorrhages. Then we made a few changes, and suddenly number of false positives came. That was very quick to retreat also. Titration was quick in AI. It was something which I was astonished.
What has been the reaction from the physicians who are sending patients to you, or has there been any feedback from the end patients? Do they know that their exams are being read by AI? And is there a positive feedback, negative feedback? What has been some of the reactions from their side?
Okay, I don't think we have informed our patients that we are using AI so far, but all our physicians know, because we did multiple webinars for store referring physicians. I still feel patients, if we tell we use AI, the same distress which I had initially would be formed in them. So we still have not informed our patients. But we are releasing AI reports adding our reports, Qure reports, overlay reports in our routine reports. I think patients, if they had researched what is Qure.ai, they would have found. I'll talk about Qure, the kind of value it provides to referring physicians. So when I saw first demo cases of Qure itself, I know the amount of value it's going to bring. So I talked to the Qure team and we deployed it in a tier 2, tier 3 town, I would say, called Tenkasi. It's in southern part of Tamil Nadu. I will give a little bit background about the town. So the town has a population of around 1.5 lakhs, and we are the only diagnostic center who have CT and MRI. For the entire district, the Tenkasi district, I think would be having more than 10 lakh population. For entire 10 lakh population, ours was the only CT and MRI scanning center. The government facilities also don't have MRI so far. And in the entire district, there is no neurologist, there is no neurosurgeon so far. There are only visiting neurologists and neurosurgeon from the adjacent main cities. And we have one radiologist. It's very difficult getting a radiologist in Tenkasi. So we have only one radiologist in Tenkasi who does everything from X-rays to ultrasounds, from CT to MR. We help her with teleradiology, but still, if there is an emergency, if CT brain has been taken for infarction or a head injury case, referring physicians call her directly and ask for emergency oral reports. So this was the case before we deployed QER in Tenkasi. And also, as I said, Tenkasi doesn't have any neurologists and neurosurgeons. Anything, any BD or subdural or extradural hematoma, large current control with shift, even a large infarct with a hemorrhagic transformation, that needed to be referred to the nearest city, which is Tirunelveli. It's around it's a 2 hours drive, ambulance drive from Tenkasi to Tirunelveli. So pre-QER deployment, the symptom to treating time for any stroke or head injury case, if the case was mild, so the patient had just a fracture without any parenchymal bleed or hemorrhage, he would be treated in Tenkasi. And it is the same kind. It's the same for stroke as well. If there is no large hemorrhage or no large infarct, the physicians there in Tenkasi will treat them. If it is a very large hemorrhage with midline shift or a large infarction case, they will be referred to Tirunelveli. So there is a 2 hour traveling time for a complex case. So complex case actually should have very less quick treatment, but since the facilities are not available in Tenkasi, they needed to be traveling to Tirunelveli for 2 hours. So it took 4 hours for mild cases to get treated from symptom to treatment. So the patient gets hemiplegia or gets into a RTA, suppose head injury. He visits the local doctor there. Doctor refers to Aarthi scans taken. Radiologist will take at least 60 to 90 minutes to give a report. Then the report has to be given to the clinician, and then he will decide whether the patient needs to be in Tenkasi or to travel to Tirunelveli. So it took around 4 hours for if the patient got treated in Tenkasi, and if he had to travel to Tirunelveli, it will be anywhere between 6 to 7 hours. This was treatment symptom to treatment time. So post QER, we were able to reduce 2 hours for patients managed in Tenkasi. So if a patient got stroke in Tenkasi from scanning, actually post scanning it was very easy. 5 minutes we got the QER. If we get the QER preliminary report, then we automatically message it to WhatsApp via API to the doctors. So they view it and they make a quick decision in the scan center itself. The patient needs to go to can come back to his clinic or needs to go to Tirunelveli if it's a big infarct or hemorrhage. So that decision making time was reduced by 2 hours, and thereby treating time was also reduced by 2 hours. And what's interesting was previously when the patient had a big head injury and had a lot of contusions and facial fractures, but with no parenchymal hemorrhage, he was still being referred to Tirunelveli. So the patient would be, maybe he would have received some first aid, but still he would be bleeding, and for 2 hours he needs to travel to Tirunelveli. But once these cases got processed through Qure, and they found out that the brain's apparently normal, so everything is just exterior. These cases which looked very complex got treated in Tenkasi itself, and for those patients we have virtually shaved 4 hours in symptom to, or trauma to treating time. So because they know Qure gave a preliminary report that there is no, maybe a fracture, but there is no hemorrhage or parenchymal contusion within the brain. They know they'll be able to manage a patient in Tenkasi itself. So he saved anywhere from 2 to 4 hours for each patient. So referring doctors, after a point of time, they stopped calling her radiologists. They send the patient once he gets scanned, before he gets down from the gantry, we get a preliminary report from Qure, and it was automatically sent to referring doctor. So they were not trying to call a radiologist while she was doing ultrasound scan. So if she is doing ultrasound scan, she needs to quickly come out. Then that's a small distraction for the radiologist as well. So that got lesser. So radiologists also were not feeling guilty in night. Since he is the only radiologist, in night also, at night 2 o'clock and 3 a.m. she used to get calls. Now that has virtually reduced, is what she was telling. She's also not feeling guilty for not working 24/7, because that's how a radiologist feels in a small city. Since he's right. She feels more responsible. So, and as a promoter, I was very proud on how much mortality and morbidity we prevented for the patients with head injury and stroke in Tenkasi. So now we have deployed it in all through Tamil Nadu, the model, Chennai as well, and soon I think this month also we'll be deploying pan India.
What you shared truly highlights the impact for both the patient as well as the referring physician and the radiologist. I'm sure she would be much at peace.
Yeah.
And then, as you said, less worry on her shoulders as she sleeps at night, less responsibility. So thank you for sharing that story. It's amazing.
Actually, we never tracked how much our patients got benefited. So we were so focused on doing the work, and we never used to get interviews or feedback from these kind of patients who were processed through Qure. The one actual feedback which I got was the patient was a father of our ex-employee. He had hemiplegia and came to us, and we took CT brain, and Qure reported a massive MCA territory infarct. It was so huge and with a large midline shift. So the report, as usual, went directly to the referring physician in Tenkasi. He directed the patient to go to Tirunelveli since it was a large infarct. So he got quickly to Tirunelveli, and the referring physician the physician in Tenkasi shared the Qure report to the treating neurologist in the tertiary hospital in Tirunelveli, and it saved close to maybe 3 hours in treatment, and he regained most of his function of his feet. And there was actual one case where I followed up till end, because he was a patient who was known to me, and they were very happy.
You mentioned that the way you have engineered this solution is that while there is an algorithm doing the interpretation, you are also using APIs and using even something as common as WhatsApp to forward that report immediately to the referring physician. You mentioned that even before the patient is out of the gantry, a report is on the phone of the referring physician. So can you talk about what is being the kind of effort and the investment, or not just investment in terms of money, but the kind of involvement from an engineering level to make this entire workflow come true?
So we used to do process engineering around from billing to the end report reaching the physician. We used to do process engineering in that area, and we found that in pathology, they used to sell pre-analytical, analytical, and post-analytical. It's pre-analytical is billing to whatever happens, and then analytical is billing to scanning would be pre-analytical. Scanning and then a radiologist reporting is analytical. Post-analytical is the report reaching the patient as well as the doctor. So in these three areas, we can improve our workflow and timing. So having a digitized history, so the patient, our technicians can enter history digitized on their mobile phone itself. They can scan the prescription form from their mobile itself, and it will be quickly uploaded. So when the patient comes for billing, at the same time, his history would be obtained by the technician as well as the prescription form uploaded. So where this helps is the radiologist will quickly view the history. He doesn't have to consult a technician. He doesn't have to call anyone. He just has to see this history and then report his cases. So there it can reduce analytical as well as pre-analytical time. Analytical will be reduced by having small workflows in our PAC systems, like reporting. The things that are very small, so miniature things, but they will say 1 to 2 to 3 minutes of time for each reports. So like having a template-based reporting and standardized reporting for all cases, and having standardized protocols for CT and MRI images is necessary, because we have around 45 MRI units as of now and 47 CT units from different makers. MRI is predominantly from Siemens, but different machines. So if each machine had a different sequence name and different sequence timing and echoes and everything, the radiologist would get a little bit confused while he's doing teleradiology and reporting a lot of center cases. And having a standardized protocol for each case, headache with giddiness, headache with seventh nerve, trigeminal neuralgia, having a standardized protocol across those centers also help radiologists in reducing time and less repeat patients also. There is no need for recalls.
Yeah.
So this is how we reduced pre-analytical as well as analytical time. And it's also not only about the quick reporting, it's also about how quick the reports reach the patient and the referring physician. That's the post-analytical part. That's being done with the WhatsApp API integration. So we are one of the very first, trial or beta users for WhatsApp API at least in the healthcare space in India. We started doing it for the last 1.5 years. So all CT and MRI reports scanned for the last 1.5 years, the reports will automatically go to the treating physician. If we have his phone number in our database, automatically done. So the same workflow which we use for Qure.
My last question, as you look at the future, as you look at your growth as an integrated diagnostic player, what more do you want from AI? What is your prediction for AI and how it should help you in the future?
So that's a good question. So AI companies, the radiology AI companies usually look predominantly they are image based. They look at an image which is unstructured and then they try to report it as much as possible. Some small errors of AI, false positives or true false negatives can be easily avoided by using common sense from a history. For example, a head injury patient is not going to have an infarct, so there is no need to have a fracture, extradural hemorrhage and an infarct in the patient. The infarct is most likely to be a small vessel ischemic change in an old patient, just misinterpreted as infarct. So once image as well as history data is taken into account, I think the specificity as well as sensitivity of AI will increase for each finding. So that is one thing that's in my wish list. Like every AI company should start getting history from DICOM images. That is one thing. And also AI companies are mostly sticking to the routine. We have always done things this way kind of protocols, and that too from US. So I think since you guys are from technology, you should have a fresh view, fresh eyes on radiology, and you need to break the protocols and form new ones based on data. Like if there is data on if people are following CT brain with CT angiogram for stroke cases, and if you can provide with data and make an informed decision that MR with MR angio is better for stroke, it reduces time, no radiation, no contrast later radiologist, as well as if you can reduce the time also and reporting time. That's something which is you need to break the protocols more. That is one of my wish lists. And MR is a gold mine for radiology, I would say. Like still a very few companies are into MR. MR you can get very good quantitative data from MR. Not only the images, you get quantitative data on diffusion and the coefficients and that will be very helpful in AI. MR is a gold mine for AI, and a few companies are only tapping it, in my opinion. There is literally no market for forensic radiology as of now, but it's not that because radiologists are reporting live patients, and there is not enough radiologists to report the patients, the forensic radiology. So I think that would be one more untapped area for AI.
Completely agree with you on MR being a big gold mine, something which a lot of companies should focus on tap. And I completely agree with you on trying to include patient history. The more we can get other information apart from the pixel data, the better our algorithms become. So we'll definitely take these suggestions and see what we can do. Thank you for your time today, Dr. Arun. It was a pleasure talking to you and getting to know you about Aarthi Scans, about your passion for getting the best quality care in an affordable price, and how you're using technology, and look forward to continuing on this journey with you and supporting you in every way possible. Thank you once again.
Thank you, Chiranjeev. You guys have been great in Qure. You have saved a lot of patients' data in a lot of patients' lives with QER.